title of the study's Pathway 2 is a British Hypertension Society Research Network study looking at the optimal drug treatment of resistant hypertension. So we took just over 300 patients who had resistant hypertension, incredibly well characterized. So we made sure they didn't have white coat hypertension by doing home monitoring. We made sure they were taking their drugs by asking them to come to the clinic and watching them take them and making sure their blood pressure didn't fall. They all had to be on 3 drugs according to national guidelines, including a diuretic. And if their blood pressure wasn't controlled on 3 drugs, they were randomized to 4 different comparisons. The important thing here was that people have often said a drug called spironolactone is the most effective treatment for resistant hypertension, but it's never been compared with other drugs in a randomized controlled trial. So we compared spironolactone with doxazosin, an alpha blocker, bisoprolol, a beta blocker, or placebo. And we used a randomized sequence so that every patient got every drug for 12 weeks, so we could see exactly which drug was the best treatment for which patient. Well, we saw that the best drug for most patients, in fact almost every patient, was spironolactone. Low dose, 25-50 milligrams a day, vastly superior to placebo and highly significantly superior to the other blood pressure lowering treatments. So this really provides us with a hierarchy of treatment for the first time. If you've got resistant hypertension or a patient with resistant hypertension and they're taking their drugs and they're not controlled, spironolactone's the way to go. I think if you've got a patient with resistant hypertension, you're pretty convinced there's no other underlying cause, the first treatment to go for is spironolactone, 25 milligrams a day. If that's not good enough, increase to 50 milligrams a day. The drug should be effective, it should be safe, but you do need to monitor potassium soon after you start treatment just to make sure it's not going up, and also periodically thereafter, depending on the patient's baseline renal function. One caveat, we didn't include people with significant impairment of renal function. So if eGFR is less than 45, I can't comment on the rate of hyperkalemia in those patients. But for the vast majority of patients, this is a very safe and a very effective drug, and it's a game changer for resistant hypertension.